and really excited about this interview podcast. I don't know what, never know quite what to call it. But Sam and I have never actually met in person. We have spoken for quite a long time, and I always get excited about talking to professionals who are modern in the way they think, even when they have been trained in a certain mindset. And I'm included within that, I think, in terms of I've got a limited amount of training. But to then have a healthy professional discussion, and that's why I wanted to bring Sam on. He's you've actually done the online I Move Freely now, and so I know from the discussions we've had that Sam comes from a refreshing sort of perspective of his profession, which I'll let him talk about in a moment. But I want to just go straight in a little bit with why I want to do this video for people, and then I'll let Sam introduce himself and his background, and you'll see why we both wanted to do this. Because as an exercise professional and a biomechanics coach, my system has trained me to start at the pelvis and then run through the body in a systemized approach from the pelvis first, and then we end up at the feet. Whereas Sam's training, he's a foot specialist, he can talk to you about that in a moment, would be the opposite way round. And so from the outside looking in, that looks like a complete contradiction. But Sam, can you explain from your standpoint, your professional background, and then your kind of, as a podiatrist, you know, what is a podiatrist, and tell us about your profession?
Yeah, no probs. So I suppose I'll start with my professional background because it puts context to it. So I trained as a podiatrist 2005 to 2008, graduated and started working in the NHS. I then did a master's degree in musculoskeletal studies of the lower limb, which started to sort of expand my knowledge a lot more about biomechanics and MSK, and then sort of took on a role in the NHS where I was working just exclusively within sort of biomechanics, musculoskeletal caseloads. And then I sort of developed an interest in exercise therapy more. And I've been looking at biomechanics education for some time. I mean, I contacted you probably 3 or 4 years ago, looking at courses, and we could never really tie a date down for me to come on a course. But I then went and did, the other issue that we had was discussion about insurances and how things would work as a podiatrist. So I then went and did my level 2 and 3 personal training because I just wanted to learn more about exercise therapy and focusing on a sort of more of a proactive approach to health and fitness rather than a reactive approach, which is very much the focus in the NHS or the focus that I was in. Someone came in with an injury or with a problem, which I had to then try and fix or help them with. Whereas the sort of fitness exercise therapy side can definitely be switched on its head and can be used as a, let's prevent you getting that in the first place. We know you sit down for 8 hours of the day at work. These are the things you can be doing to stop that becoming an injury. So that's my sort of interest and where it's all come to and brought me to now. With regards to your question, I'll be controversial straight away if you want. I don't start with the feet in the slightest bit. I start with, the patient, first contact with the patient, they're in the waiting room. I look at how they get up out the chair. I look at how they walk to the clinic room. Back in the days when we used to be able to shake people's hands, do you remember that? I used to, that's start of your neurological assessment, their grip strength, are there any tremors? You're building your assessment straight away. Realistically, with some patients, it's 10 or 15 minutes into the appointment before we look at their feet. And actually it's been 10 or 15 minutes of medical history, of history of their injury, what's brought them there. So it's quite a lot more goes into it before we start looking at the feet themselves. But obviously the focus of our profession is the foot. I mean, the technical definition, and there's different definitions out there and different podiatrists might look at this differently, but I always think of it as the foot, ankle and associated structures. So we are technically specialists in the lower limb, but we predominantly focus on the foot and ankle. So with that in mind, yes, obviously a lot of what we do focuses on the foot, but that is because somebody is probably coming in with a foot problem. heel pain, ankle pain, hallux valgus bun, you know, something along those lines, rather than coming in to see us with shoulder pain or back pain. That's not to say we don't get people who come in with these problems, but that's normally from a referral from a physiotherapist or an exercise professional, or someone who said, I've tried this, that or the other, it hasn't worked. I've noticed that they've got flat feet. Can you try something, you know, as a multidisciplinary approach? Not many people would think, I've got shoulder pain, I need to see a podiatrist, which is rightly so. You know, but we can form part of a wider team in that sense. So in answer to you, I suppose, that first question, yes, I don't focus on the feet to begin with. They do come later on. But then that's me managing every patient. I suppose to put a bit of context to my profession, we don't just specialize in biomechanics and musculoskeletal conditions. We focus on all conditions to do with the feet. So in private practice, we don't sort of focus on one area. So we treat skin problems, nail problems. We do minor ops, you know, nail surgery and the local anesthetics. We can use local anesthetics, steroids for injections. We can provide antibiotics. We've got prescription only medicines license for using certain drugs. So we've got a range of skills that we can use that are all geared at the foot, at treating problems of the feet, rather than just biomechanics or sports injuries. So it's a bit more complicated, I suppose, in that sense. And I think when you consider the fact that we're an allied health profession, I think at some point there had to be a restriction put on the scope of practice of the profession, because you can't get your licenses, you can't get your insurances unless it is restricted. So I think therefore it has historically been restricted to the foot, ankle and associated structures. Therefore, by default, we go to the foot.
And I think that's really enlightening for people who might watch this that are not from a podiatry background. And this is what I want to really expose, because I don't know if you find as a podiatrist, you are perceived as, well, that's it, you're a foot specialist. And I'm talking about kind of the end user. So the client, for example, who is sent to you, well, you deal with feet. So you're the foot guy. And yet you are way more than that. However, you've chosen to extend your training beyond being simply a podiatrist, and I'm not underplaying podiatry at all, but what I mean by that is you clearly felt there was more to it than looking after feet by looking at the feet or the lower limb, and so you explored it in more training, and conceptually people, I'm talking about again the general public and maybe non-podiatrists, have a perception of professions like podiatry as well. If you're just focusing on the feet, you're missing the rest of potential contributing problems in the rest of the chain in the integrated system. Is that, I'm guessing, I don't want to put words in your mouth, is that why you did further training, because you didn't find all the answers by doing podiatry, or is it because you didn't want pigeonholing? What was it that took you further and decided to expand beyond? Because podiatry is a degree, it's a big training, it's a big course, to then go and do more big training, if you like, more intensive training. It's a lot of money, it's a lot of time. What was the purpose in doing that? Was there something missing, if you know, from podiatry?
Yes. There's something missing in everything, though, isn't there? There's no one complete medical qualification. I mean, you could argue doctor, but then doctors then they specialize. You know, there is no there's no one overarching qualification you can have that teaches you everything. So it's a good question, and certainly when I began training and working in podiatry, I knew that I wanted to develop into sports and biomechanics, and that sort of side of and managing sort of sports injuries, running injuries. Running was running was the catalyst,
right?
Because looking at, I enjoyed running I still enjoy running. I don't do it as much as I used to, but I definitely had a phase in my 20s where I ran a lot more, and was working a lot with people with running injuries who may come in with ankle pain or heel pain, maybe managing their problem with reactive treatments, maybe a steroid injection for the heel, or maybe foot orthoses exercises. And then they would go away, then come back in 6 months with a shin problem or a knee problem or something like that, and say, oh, my orthotics need tweaking. And you sort of start to think, right, in the 15 minutes I might have had with them, but then yeah, fine, I can do that because they've come in with that. But actually, that's not the only problem. Let me refer you to physiotherapy. Maybe they go see the physio. I'm talking within the NHS remit, so within the I suppose within the referral pathways I had, I couldn't say, oh, you need to go see a biomechanics coach, because everything has to be within the available referral pathways. Very different in private practice. But I think I was quite restricted in that sense to having to treat what was in the remit of podiatry, particularly when you get into NHS with block contracts and what a department, the work that a department is supposed to do, that it gets a bit more of a grey area. In private practice, you can certainly do a lot more, but then you've still got your insurance, you've still got you have to be practicing within your scope of practice. Like I can't be giving someone acupuncture in their back, because they've come in with a foot problem. I'd have to be doing that under a separate qualification or something. And I have always been very careful with how I've done that. So I've been a podiatrist and also a running coach for a period of time. And while there's a lot of crossover, they're two completely separate things within what I'm doing. I've lost track of your question now.
It's about really perception of podiatry, and then you deliberately expanding. And it's interesting just what you just said then about, as a trained podiatrist in the NHS, and you treat somebody with a foot problem, but they come back with another issue, which makes you think, all right, okay, well, we've got to adjust something. And so that really hits the nail on the head as to how biomechanics coaching came about. And I think that's where you and I have this synergistic set of concepts, even though we're quite different. Our professional expertise is quite different, but the basic fundamental principles are understanding the body as an integrated system. So understanding your maybe frustration within the NHS, of the limitation of the NHS, and then obviously taking yourself into private practice and developing your training, but then working with runners, working with people with foot problems. Is there still a problem with perception of your skill set? Understanding what you've just said about remit and qualifying and insurance and everything else. I hear all of that, and that's really important. But the end user doesn't care about that. They want to see a foot specialist because the foot hurts. Yeah. Is there an innate problem with that?
No, there's nothing wrong with them coming to see a foot specialist because their foot hurts. Right. But certainly the podiatry profession is still trying to shake off shackles of the C word, chiropody, which is very much the origins of our profession, in the sense of being focused around chiropody, which was definitely focused more on skin and nail treatments. Yeah. The role of biomechanics and musculoskeletal podiatry is relatively new in the terms of, well, it's not new, but it's growing rapidly in the more recent past of the profession. So it's certainly trying to shake off those sort of stereotypes. But yes, also appreciate what you're saying with, we are still very much seen as the people who would help with a foot problem rather than another problem that could be related to the foot as a first line. But we should be thought of as more of where our piece in the jigsaw of the entire body. Yeah. But yes, I think in answer to the previous question, yes, that is why I wanted to learn more, because I wasn't satisfied with the concept of an arch support, an orthotic fixing X, Y, and Z. I needed to know more and more. And I think as well as that, when I did my master's degree, which I did while working in the NHS, I did it part-time over 3 years, looking at the research behind foot orthotic paradigms or orthoses paradigms, looking at the research behind foot biomechanics, or the research really behind any biomechanics, you can pull it apart quite aggressively, quite easily. And I think the research sort of approach to things, a critical review of things, right? It needs to be there without a doubt. We need to critically appraise research, but it can be so aggressive that actually what you're left with is nothing, because no piece of research is perfect.
Yeah.
So it's a very tricky thing, because that can actually make you quite it can give you quite a negative opinion towards any therapy. When you look at randomized controlled trials that show it to be ineffective, and that's true, that we need to research. I say we need to critique things, but I think what the master's degree did was teach me about the limitations as much as anything of my profession, and therefore, yes, I wanted to expand out and learn more and more.
Which is great, and again, I think where it can be an eye-opener for people watching this to appreciate different ways of looking at things. So if somebody comes to you with what might be a common problem they come to you with, and where would you start? Let's say, what would be a common foot problem?
I mean, the most common musculoskeletal foot problem is heel pain.
Right.
Which is often called plantar fasciitis. Now, I mean, plantar fasciitis has become a household name, certainly within health and fitness professions. I'll go out on a limb and say most heel pain isn't plantar fasciitis, but it's a term that we use. Fasciitis is basically the plantar fascia being a connective tissue that runs through the arch of the foot, through the sole of the foot. Again, there's no arch, not technically an arch in the foot, so we use these terms, but through the sole of the foot and attaches to the heel. And when that becomes inflamed, technically, itis being an inflammatory condition, that is plantar fasciitis. The majority of cases of heel pain, when the plantar fascia is involved, we're actually looking at more of a degenerative state of the fascia. So we're looking more at a plantar fasciosis or a plantar fasciopathy. Again, going back to what you said before, patients don't necessarily care about this. Some do. Some really do care. Others just want you to get their heel pain better. But certainly with something like that, then we would immediately, our sort of process that we follow, and it's interesting actually. You've mentioned when we were doing the I Move Freely course, I think you mentioned right at the start that if somebody has an injury or an ailment, that you don't offer the therapy, you don't offer the exercise therapy. Obviously that's different in our profession, because that's why they're there. So they're looking at a diagnosis, they're looking at finding out why they have that problem. So generally go for a process of history. So you take a history of the condition. Was there a gradual onset? Was there a sudden onset? If, for example, a sudden onset might suggest maybe they've had a rupture or a tear of a tissue around the heel. Did it come on? Is it worse in the mornings? Most sort of heel pain, people get out of bed, go to put their foot to the floor, and they can't put their foot on, to put their weight through their heel. They hobble for a few steps, and then it eases a little bit by the time they've got to the bathroom, and then sort of go down, have some breakfast. It's eased off a little bit more, but then maybe they sit down at work and then go to stand up at work to go to the printer, and again it's there. They can't put their foot down. So that's that sort of reoccurring. This is what the history is. Just getting this information, it all helps us start building the picture. Observation, then I tend to do sort of weight bearing and non-weight bearing assessment. Then so I'll get the patient standing, looking at the way they stand, maybe get them walking a little bit around the room, and just have a look at maybe a brief overview of their gait, get them to sit down, look for any obvious swelling. Sometimes you might see something very obvious, and you may see a lesion, a foreign object or something, in their heel that's causing the problem. That's quite rare. Most people have already looked into something like that, but looking at observations. Then when we start working through tests, so looking at range of motion that they have available in the foot and ankle and lower limb, power testing, muscle strength testing, quality of motion, direction of motion, and then you can start sort of any other tests you may want to do. You may want to do a neurological test, a vascular test, thousands of tests that you could do. You have to, in the time constraints, you have to pick the ones that are going to give you the results you need. And then palpation. This is a very key point of our profession, is the ability to know what is where on the foot and ankle, and actually put your thumb and fingers there and feel for pain, discomfort. Sometimes you can feel a swelling, or you can feel a nodule in the fascia, which is sort of indicative of certain conditions. then sort of based on that information and based on the level of pain or discomfort a patient might be in, we can look at more functional tests then. So we different versions of gait analysis or maybe running analysis. At the clinic where I work, we have pressure analysis. So it's a pressure platform that you sort of stand on, and it gives you a feedback, gives you data onto the computer of where weight is going, get a person walking over it, and it tells you where the forces are going through their feet at a certain time. And all of these things help to build a picture of what problem they have and possibly why they have it. Then we can...
So that's what I want to talk about, because I understand all of that side of things. But what I'm intrigued by in when you're coming from the podiatry perspective with obviously the MSK that you've got as well, and you identify what is happening. Mm-hmm. Let's take plantar fasciitis as the diagnosis. Mm-hmm. Why do they have it? Would be then the next question, i.e., is it an injury? And let's say it's not the injury, let's remove that for now. Is it the way they're stacked up? Is it their shoes? Obviously we won't use that one, but let's just for double argument say it's the way they're stacked up. Mm-hmm. What would you then do about that? And how would you identify about the way they're stacked up? And you can...
When you're saying stacked up?
Well, let's say, for example, as a biomechanics coach, mm-hmm. we would assess every joint and structure within the system.
Yes, sort of alignment.
Yeah, kind of. Function of the pelvis, spine, shoulder, knees and feet, mm-hmm. Myofascial, skeletal and neural. So we would test all of those. Mm-hmm. Similar to you, but from an exercise movement perspective rather than a clinical pain perspective. And somebody I have come to me is, whatever you want to describe, off-centre, mm-hmm. positive for dysfunction of the pelvis and spine and so on. And they have a functional leg length discrepancy. Mm-hmm. And they might have some plantar fasciitis as well. And so you and I work together. Where I would start is with the pelvis, as mentioned earlier, to reduce any excessive pressure through one leg over the other leg when they're walking through gait. Mm-hmm. So with your testing and knowledge and expertise from the foot up, where would you start in that process? Let's say you and I were working together with this client. Would you start then at the feet, or how would that work for you? Or would you not do that? How would you view that?
No, yeah, I appreciate exactly where you're coming from, yeah. So I think I would do there'd be a lot of crossover in our testing. So I would use things like, for example, supine to long sit test to be looking at functional true leg length differences. Looking at their pelvic symmetry. When I'm doing gait analysis, I'd be looking at their pelvis. I'd be looking at knee position. In the patient you're describing, if we're sticking to sort of a textbook example, maybe, yeah, you'd expect to see that perhaps that leg dipping into more of a then the knee going into more of a valgus position, and then perhaps more calcaneal eversion on the longer side, which you could then argue is increasing sort of elongation of the medial arch of the foot, and therefore increasing tissue stress through the plantar fascia. So then its medial insertion on the heel will be under a lot of stress. So yeah, the foot is probably the victim in that instance. Yeah. Rather than the cause. So a phrase I very frequently use to patients is, what we need to use then is I call it a bottom up, top down approach.
Right.
So they could walk out of, I could do something there and then, which to try and help their symptoms, but we need to address the underlying issue. So, and that's an interesting point, because that's where our approach is to doing that. And probably what's guided me towards wanting to do the course and things with you is how a podiatrist would address pelvic dysfunction, because that's challenging. Yeah. You'll be glad to hear that most podiatrists, I will go out on a limb and say, I hope most podiatrists won't stick a heel raise under the short side.
Yeah. Well, and this is the thing, I think, what I think you and I want to do through this video is support podiatrists and foot specialists who know a hell of a lot more about feet, certainly than my training. Your training about feet is, far more extensive, and how we can work together rather than judge a profession and rule it out as one of our multidisciplinary team. So obviously they need to have an open-minded approach, hence yourself, and our conversations, rather than maybe an old school concept of putting a wedge in the short leg. My experience of talking to podiatrists over the years in general is a very open-minded group of professionals, because we can demonstrate, for example, changing something in the shoulder that can change a foot test that we would do as a movement professional, and it can change the result sort of at the other end of the body. And that's where I think you and I come together, is that appreciation of that. So I don't for a minute think I'm a foot specialist at all, but I know when I want to send my guy to you, and then you have the same, I believe, appreciation for what I would do from up above. So almost, and I think it comes back to what you were saying earlier, Sam, about remit, profession, insurance, and, you know, while your qualifications now are extending to mine as well in terms of the whole body approach, helping people be aware you don't need to know everything, but you need to find professionals who are willing to discuss with GDPR and client's permission and everything else, how we can have this bottom up, top down approach, which I love that analogy. And I really like your way of positioning that to a client quite simply. We can give you a quick fix, but actually it could be that it's coming from your pelvis. So as a podiatrist or somebody coming with a foot problem, how is that received? Are they generally quite good? I'm sure you're a very good communicator, but how do they receive it in that way? If you're going in for feet, you look at the feet, but you say, actually, you need to do a pelvis exercise or something.
Well, that's an interesting point, because I think a lot of that comes down to how you manage your patient's expectations. One of the early questions I'll ask in an appointment, whether I'll ask it literally or whether I'll ask it, you know, in a manner, is to effectively find out what their expectations are. What they're hoping to leave the appointment or series appointments with. If their expectations are unrealistic within the scope of podiatry, I'll discuss that with them straight away, because those are the problems that lead to complaints. They're the problems that lead to issues when patients aren't happy because they've thought you're going to do one thing where actually you can't do that. And that's a dangerous area where you see people, for example, on a cruise ship, you see foot orthotics, you know, orthoses for £300, and they'll cure your headaches. I'm plucking that out the air, you know, but I've heard of those sorts of things. But effectively, you know, where's that come from? Where's that information come from? When those patients buy those and then go away and their headache doesn't get cured, they're pretty disappointed. So managing expectations is an incredibly important way of how you go about that. And then it's just a frank, open discussion. People are there for your opinion at the end of the day, certainly with complicated conditions. But let's look at that patient with plantar fasciitis. So that's our working diagnosis. Pain levels 9 out of 10, struggling to weight bear, in agony. You know, by the end of the day, after working all day on their feet, they're in agony. So they want something done there and then. They may be very interested that it's coming from their pelvis, or that it's related to their pelvis, but they want to be helped there and then.
Yeah.
So perfect example of a patient like that would my sort of treatment, not example of patient, but what I would do for a patient like that would be look at the immediate things I can do to help them. So it may be improving their footwear, maybe giving them a sort of foot orthoses, or maybe a strapping technique or taping technique, something that we can do to mechanically alter the stress going through the plantar fascia almost there and then. And it is miraculous sometimes how quickly you can do some of that, and it does have an instant response to that patient, but you haven't treated the root cause.
Yes.
And if I think that's the case, I'm very, you know, I explain that to them. It is though possible that actually that tissue just got overstressed, upset, and actually if you calm it down for a few weeks, it might just improve, and that dysfunction that we're possibly observing could have been an effect rather than a cause. So things do. The body is always trying to heal itself. So sometimes it just needs a bit of a helping hand. That person's been on holiday in flip-flops for 2 weeks and they've just really stressed their foot out. So we can do things there and then to try and calm it down. But it's then that further discussion of where do we go next, which is, and I'm very lucky to work with osteopaths and physiotherapists in private practice. And that's where I would bring them into play to say, I've got this patient has got a functional leg length difference. I might review them after 6 weeks and their heel pain is 80% better, but I'm still seeing the same functional leg length difference. And that's when I might say to the patient, well, look, the pain's better. I am observing this. Do you want to see what this is? Take this a little bit further in a bid to try and prevent this coming back. And that's when some people will say yes. Some people might say, no, I'm perfectly happy. And those are the sort of the ideal world. It'd be that my interventions would calm the symptoms down, but then the patient would then maybe see someone else that would help with treating any other dysfunction more proximally through the body. But that, I suppose, is why I've been trying to expand my scope of practice with I'm a 3D course and the likes, because I do give out exercises for that. I would give out glute strengthening exercises or those sorts of things to try and look at dysfunction or trying to, but I mean, I'm stepping into your waters now, and and I'm sure there's a lot of sharks listening. So that's where we start to sort of, I am newer to that area. I'm learning about these sort of things and where that can impact what I do. But that's where the handover would be, in a sense of.
Absolutely. And I think when we talk about what I'm keen for people to hear is what you just said about when somebody is in pain, the recognition that we need to help calm the system down, get them comfortable, and then focus on what needs to happen, rather than, because there's the perception, isn't there, it's just a quick fix. He's just whacked some tape on or stuck a wedge in, or, and that kind of lack of knowledge of what the professional was actually intending on doing, which gets misinterpreted maybe by the client and told to another professional who says, well, that podiatrist clearly doesn't know what they're doing. They've just done a quick fix, which isn't actually the case. And I think that happens quite a bit, is the Chinese whispers from the professional podiatrist maybe, who actually communicates really well, but the client doesn't hear it in the way it was intended. They don't go back because their heel feels fine. And then they go to see, for example, a personal trainer or biomechanics coach. They say, oh yeah, they just put a wedge in. And the PT's like, well, that wasn't what you needed. It's So I think there's often the truth of what's going on gets watered down and then totally misinterpreted. And I want to try and support all professionals to always respect another professional until that the client may well have completely slaughtered what was actually going on. And we should always be completely respectful of another professional when we haven't actually had a conversation with them, because we don't actually know if that's what happened or if that was what was going on. So I just wanted to say that for anybody who's watching this, we must completely support each other. And like you have done and I do, is build a team around us so that we can work together and collectively, rather than sending people away who may then, the information may get watered down. Is that?
For sure. And keep good notes.
Yes.
And back things up with letters. Yes. To your patient, wherever possible, or reports. Because communication is key. And I remember reading some research when I was at undergraduate, and I'm not going to try and remember the stats, but it was that an incredibly small amount of information is actually taken on board by a patient during a consultation, by anybody, not just anybody in that sort of scenario. So the more information that you've got, I keep very thorough notes. I'm often have the mick taken out of me by my colleague for writing essays, but I'd much rather have an essay I can go back to 5 years later when someone comes back. And to any health professionals out there who have ever, if the majority of people won't take offense if you approach them and ask them nicely what they did, because what they did, I'm sure, was the right thing to do at that time.
Yes.
And then, the patient attitude changes. People forget pain as well. They forget how painful something was.
Yeah.
And if they've come in an appointment and they're in agony with their heel, but then a year later they find these bits of plastic in their shoes and say, why did I have these? Why did I get these? They've sort of forgotten that they were in tears in a room a year ago. But yeah, that's a very good point. And I think communication between professions, and that is what this is all about. That's why doing courses is great, because you meet new people. Communication between professions is so important. So yeah, get out there and make contacts. Find people who work down the road from you, or even in the building with you in some instances, and find out what they do, and ask them when they'd want to see one of your patients. In what scenario would they want to see one of your patients? Because that's half of it, really, isn't it? They'll explain what they do. And
I think it's also something that clinicians are trained in that the exercise world is not, is transfer of meaningful information, report writing, and that side of what you do and what you're trained to do as a clinician. And we're not. We write a case study in our exam. We write a program, 8 reps, 3 sets, and then we may periodize it, and we might do fat calipers and sit and reach. Is as a basic training. But then to work with you, generally, I think the trend is, go and see my mate. But rather than a written document that's transferred with meaningful information and then passed back, and then again it comes back. And I wonder whether our profession, the exercise world, has a stigma around it, and maybe rightly so to some degree, about our level of skill in that sort of side of things, not just we're really good at exercise. We are the exercise experts, maybe over the clinicians very often, I think, in the understanding of movement. But I think where we really lack, and I'm hoping that SIMSPA, who is our new Chartered Institute for the Management of Sport and Physical Activity, they're our new standard and governing body, are bringing in a chartered practitioner status within our field. So that's one of the things that you've mentioned that I think we're really bad at. I think we're really poor at. We're not trained in it. We're not skilled in it. That I want people to hear what you've just said, that if they are an exercise professional, that is a skill that I think allows for meaningful transfer of information. If we are writing notes and then, with permission, passing them across, rather than sending them to Barry the physio or podiatrist down the road and then say, oh, what did he say? I think that's where it often gets lost, misconstrued, misunderstood. I don't know if you agree with that, because you're setting, you have a group around you, don't you? So you don't probably have that issue.
Well, I have a group around me that I access, but yeah, and it's, I think report writing and note keeping is just ingrained into you from your basic training onwards, and particularly then when you start working in rounds with insurance companies. When insurance companies are sending you patients, they always want to report. They always want to know exactly what the situation was and how many appointments potentially they're going to need and this sort of thing. So yeah, I think it's just part of it. But it's interesting you said about exercises though, because the amount of times I've written notes myself or seen notes where I've looked back and I've just put, issued calf stretching 1 minute 4 times a day. What does that mean? Really, what does that mean? We've actually started using an online resource now, which is brilliant, because you can send videos of all the exercises, and it actually saves the plan that you've given the patient. It then sort of saves it. But another point you just mentioned was periodization and progression through an exercise plan. We're not good at that, because once a patient's got better, they tend not to come back to see us.
Yeah.
So there's no sort of development to the next level, which is quite tricky. So there's a lot of crossover that we could all learn from one another. I mean, ultimately we're in the same field, so it's just a case of just finding a way of sharing that knowledge between professions.
Yeah, I mean, ultimately we are both in the arena of bodywork, human movement, helping people. But what I want to make sure we do tap into within this particular video, and I think before we even began this, we knew that this could just go on. So I just want to bring it back, because I would like to talk about gait analysis and orthotics.
Mm-hmm.
What are orthotics? Foot orthoses? How do you use them in your clinic? Is gait analysis part of that? I know you've mentioned it already, but can you just
have we got a few hours, have we?
Because I think the orthotic thing is probably the controversial part of our link, not me and you, but like our professional link, in terms of orthotics being perceived as good or bad on either side. I'm just interested actually for you to just express your view on
it's
that.
a very, very tricky one to summarize, and it's a huge thing. And I think the key point to consider here is that, I mean, we use the word orthotics, insoles, or the plural is orthoses, so technically a foot orthoses if you've got a pair of them. They have received stigma in the past, and there's been instances where they're probably given out for the wrong problems or when they're not needed, but they serve a fantastic purpose. And I suppose very broadly to categorize it, they can be used for people who have got maybe a functionally, a foot that is functioning properly, but they have your plantar fasciitis symptoms that might be coming from a more proximal issue or from an overuse issue, where an orthosis could be used as a short-term measure to reduce tissue stress, allow healing, and then probably the patient will just find that they stop wearing them as much over time, and because actually maybe the issue has resolved itself. There are instances of that. And I think maybe that's where a lot of debate, or people have got frustrated with them being issued for patients who have a functioning, something that could function perfectly well without a medical device. That's where the issue is with them. Because the other side of the other sort of side of patient category of patients who need them are people who have a dysfunctional foot. So they've got a structurally reduced ankle joint range of motion, or a structurally reduced first MTPJ range of motion. There's, aside from manipulating, let's say that range of motion can't be increased with manipulation or anything like that. That is structurally reduced or fused, or they've got midfoot arthritis, or they've got a bunion and hallux valgus with first MTP arthritis. Foot orthoses in those sorts of patients can be literally the difference between them being able to walk all day or walk for 2 minutes, because the foot is dysfunctional, and no amount of therapy or surgery is actually going to restore the foot's function. You can look back and say, why is that the case? Why do so many people out there have dysfunctional feet? Well, we go into shoes from a very young age, so we lose, potentially a lot of what we may have. Our feet would be a very different shape if we didn't wear shoes. The toes would be splayed, more splayed. We'd have a lot more, I'm reluctant to say strength within the, muscles within the feet, but our feet would be different if we didn't wear shoes. And we go into shoes at a couple of years old. You look at a baby's foot, and the toes are sort of fanned like this. You look at an adult's foot, and that's happened. It's no wonder the mechanics alter. Also look at the fact that in over the last century, the size of a human being has just gone through the roof. And we walk around all day on concrete now. So there's things that the natural foot has not. We don't have natural feet anymore. So a lot of the debate around foot orthoses and why they're bad often comes from people saying, "Oh, your foot's, it's not natural. Your feet aren't. That isn't the way that they function. The orthoses stop them functioning the way that they should function." In principle, yes, of course that makes sense. But if the foot was dysfunctional in the first place and was never actually going to be able to function normally, because again, that's a huge thing. What is normal? Then there isn't a normal, just for the record. Then that's when they can play their part. So they can be used as a short-term management of stress on a tissue that's going to heal, or they can be used as a long-term way of altering forces going through the feet to try and just make someone's life easier and reduce pain, reduce symptoms, improve function. Can that have a knock-on effect at times? Yes. And then you're looking at trying to mitigate that. It's a very challenging one. I mean, that's a huge topic that, and I'm probably going to potentially get backlash off things I've just said. Then it's a very difficult one to, and something that is heavily scrutinized. And I will say that the majority of podiatrists are not as reliant on foot orthoses as people may think we are, and I hope that's music to people's ears. But when we do issue them, we have to justify why. We're trained to justify why. We have a series of tests. We have a series of theories that we follow, and we try and always explain why we're doing that and what the reason for it is, what the outcome is. But yes, you asked what a foot orthosis is. I mean, it's a medical device aimed at sort of altering the forces going through the foot and associated structures. So it goes inside the shoe, and basically what we now know, the effect of it is a lot more kinetics rather than kinematics. So whereas perhaps the traditional thought process was you have an arch support for a flat foot, or the heel is in an everted position, so you're putting medial rear foot post to straighten the heel back up. Those are sort of older thought processes which we have evolved away from as a profession, or certainly should be evolving away from, and into more of a thought process looking at the kinetics of it a lot more. So the point being that you could have two people whose feet look the same. Say, picture someone who's got flat feet, their heels point out, their medial arches are quite low. You could give them each an foot orthosis with the same characteristics. One person's foot might do that, the other person's foot might stay like that, but both of their symptoms might improve.
Yeah.
So we know that it's not just a case of angles and aligning a foot. It's not about that. Those words, that terminology is still often used in clinic, and I don't think there is harm in that, because it's an easy way or a quick way of explaining it to a patient. It becomes harmful if somebody tries using that as a sales tactic. That's a little bit different, and I'm proud to say, as a profession, we don't do that. We aim to ethically provide the right device for somebody's needs. Yeah. We sometimes get patients in telling us what they need. I need an arch support. I need something to lift my foot back up. But we just have to tread the line very carefully. We have to try and explain and educate the patient, as well as giving them what they want if we agree with them. And that's caused a few debates in the past. For me, somebody comes in with this device they've had for 20 years that is 4 inches high under the medial arch, and I'm sort of saying, well, actually, that's making you walk on your fifth ray and causing a load of problems down there, and putting everything else in a difficult position. So, but yeah, we have a lot of difficult conversations with patients around the use of orthoses. But I think as a profession, we're very appropriate with our use of them.
Yeah, and I think it kind of goes to show, if people are opposed to orthotics, if you're wearing shoes, in some respect, you are wearing a foot support by wearing a shoe. The orthoses are more measured in terms of, if you have them, you've been prescribed them by a skilled podiatrist who measures your feet and makes it appropriate. Whereas shoes, you go and buy your fancy Nike, whatever they are, without any prescription to them. So you're running more risk just by, whacking any old shoe on your foot, potentially. I don't know.
No. I agree completely with, and we're already changing the mechanics of our feet with our footwear.
Yes.
And there are barefoot runners, barefoot walkers, all sorts of people out there, but not everybody can. I've tried barefoot running because I read Born to Run years ago. I love it. I'm a surfer, a martial artist. I love those sort of concepts, but both of my big toe joints have been broken in the past through martial arts. I can't run barefoot because I cannot achieve the range of motion to allow it. Plus I'm 15 stone. There's a lot of things that I tried it over a long period of time and just kept getting pain in the ball of the foot, kept getting calf and Achilles pains. And I tried every possible transitional approach. So not everyone can function barefoot. maybe because of injury, or maybe because of the fact they've worn shoes for 40 years and then one day decide they're going to go barefoot. And so yeah, we're already altering our mechanics, definitely. Yeah.
Yeah, and I think one of the things you said really hit the nail on the head, which I hope that we as an education provider help professionals understand is, and it's quite difficult sometimes conceptually for people, I think, for the exercise world generally to get their head around, is that function, movement and forces are of more importance than alignment and symmetry, even though we might use symmetry testing, for example, in leg length, for example, you've got a symmetry test there. And again, some leg length discrepancies are structural, some are functional. Structural you can't change anyway. If they're not symptomatic, don't worry about it. If they are, then you consider things. Functional asymmetry is more about the function than the symmetry. And so I think you're saying that about, in your example of the calcaneus, with somebody with a dropped arch or something, it is helpful again that you basically reconfirm for me conceptually how we're hoping to help movement professionals understand measuring of the human body in itself is flawed. Every movement system is flawed. Every measuring system with the body is flawed because, as you rightly said earlier, we're all so different. You cannot get everyone to fit in a certain box or paradigm of, right, your ASIS are now level, great, that's what we wanted to achieve. That's not what we want to achieve. And it's really good to hear you use that sort of description of your paradigm. And I think that's where you and I gel, is that the basic principles of what we're trying to do comes from that same kind of paradigm of force and load, which I think, again, the uneducated in podiatry, so I'm thinking of my audience who we are generally not educated in the foot, are focused on alignment. And so to hear that again, it isn't, orthoses are not about alignment, it's about the alteration of force production, is what I heard.
Yes. Orthoses traditionally were based around alignment, I think, and still are, and some people still use those descriptors, but we know from research that the way they work isn't to do with alignment. Yeah, it's more to do with reducing forces going through certain tissues, which has a knock-on effect on pain, symptoms, etc. Yes, basically. But the reason that alignment and angles is ingrained in nearly every biomechanics profession, or anyone who, is because it's available.
Yes.
I don't have an accelerometer, or I don't have an EMG kit for testing muscle activation in clinic. I can't put probes into every patient's glutes and watch them work, walking to work out if their left or right is firing quicker. So we have to use more available tests and make educated guesses, I suppose. But it's we try and use muscle testing, and that's why we've bought the pressure analysis kit in Superfoot, because of that exact reason, that it's giving us more understanding of the forces going through the foot rather than just our observations. And that's why people use muscle testing and strength testing and various things like that. But we still, it's human nature to look at, to assess what you see, isn't it?
Yeah, and I think it comes back to what you said earlier about research. It's all we've got. And so while people say, oh, research, you prove one thing and then you'll prove it's not on the other, another paper, the same thing is proven either way. And I think this is the same kind of thing, is it's all we've got. So while we recognize it's flawed, I think the true skill comes in the interpretation of what alignment is telling us, or force production, or
what's leading to that alignment.
Exactly. So
which isn't always repeatable. It's not the same reason in every patient.
Yeah, no, exactly. I'm aware of time, and I know we can go on, but what I want to do, and it may be that this with this webinar, this video, hopefully I can use it as a podcast as well, with your permission, inspires further questions that we can maybe do this again and maybe go into. I mean, I could talk to you all day if I'm honest, Sam. But what I want to do is two things before we can close off, if that's all right with you, is you said, if I can quote you, if I may be so brazen, it would be really cool if you could encourage more podiatrists to do our courses, to learn lots, as they would, you know, being able to spend money on CPDs and understand the rest of the body. Are you saying within that sentence that podiatrists understanding the rest of the body would be helpful in terms of them being able to refer? And if so, how do you see that in the future of podiatry and the exercise world coming together? Should there be a common education, or is it just down to the individual and us exposing them to other concepts and trying to bring them together?
Yeah, it is ultimately down to the individual, because some people go into podiatry and their focus is diabetic foot ulceration.
Yeah.
It's not, I can't speak for an entire profession in that sense. And I please don't accept, nothing I've said during this is speaking on behalf of the whole profession. Yes. I have my path has been my path, and it's been based around sports and mechanics and various things. If I would say, if you're a podiatrist, physiotherapist, orthotist, anybody in these medical professions who would like to learn a different angle, a different approach to the way things are being done, then learning about exercise therapy, exercise prescription. I said physiotherapist, then, obviously they do a lot more of that in their profession, so perhaps bad example, but learning more and more about the way that exercise is prescribed is incredibly useful and incredibly helpful. And certainly what I particularly liked about the I Move Freely course, and something that I'm thinking about building in with that, is sort of looking at a movement clinic that maybe I could offer once a month or something at the podiatry clinic for those patients who have got better, but they're interested in maintaining their health, fitness and mobility. And that might be patients from the physio, it might be patients from the osteopath who just want to do these sort of low-grade exercises which are just going to help maintain their movement abilities. And I think, it's the whole wide world out there, and we're very, very naive if we think that any training makes you the complete expert of something. You can always keep learning. So that's my mentality, just keep learning and keep doing courses. Not everyone's going to share that, but yeah. It's something that I'm passionate about.
Yeah, you can tell. So anybody watching this, how can they find you? Because I personally, as a biomechanics coach, want to be able to recommend to both my biomechanics coach learners and other practitioners watching this who are not foot specialists to use your facility. You've got a couple of facilities. So do you want to just talk about your clinics, how they can find you, social media, websites, fill your boots, tell them where they can find you and how you can help?
That's absolutely fine. Yeah. So I actually, it's not my business. I'm actually employed by a podiatry clinic, which is called Superfoot. So that is SUPA and then foot. If you look at superfoot.com, we have a clinic in Cheltenham and a clinic in Birmingham. While I am an employee, it's a relatively small business. It's run by a lady called Emma Price and her mum, Catherine Price, who are both fantastic podiatrists. And I was sort of their first employee, clinical employee, I think. So I've been with them for a few years now, and I sort of left the NHS last year because they offered me a full-time role. And I've thought about setting up my own practice in the past. I can't do it as well as they've done it. So I'd rather work for the best than compete with them.
Yeah, fair enough.
They're both fantastic practitioners with great sort of business mindset and clinical mindset. And I've sort of just slotted in there and brought in my own range of skills that I developed from all of my training. And we all just work. We're a wider team now. We've got more podiatrists coming in. So yeah, superfoot.co.uk. just Google Superfoot.
Yeah, I think you come up with Superfoot, actually, SUPA foot.
Yeah, and have a look at the website. You can read about all of us on there and the clinics and things that we offer. Obviously, that's only 2 clinics, within the whole country. So, but Birmingham, I think a lot of people, Midlands based, I think, from what you said before. So Birmingham's obviously up there. But there's podiatrists all over the place. So have a look. And that kind of brings me, we said about doing another talk in the future, and I've actually sort of with Emma, who is the part owner of Superfoot, or the owner of Superfoot Cheltenham, I should say. Her and I have actually set up, or are setting up, another business at the moment, which hopefully is going to be a bit of a resource for information for people about podiatry. I don't want to say too much at the moment because it's very much in the pipeline. Website's being developed at the moment, and we're ploughing loads of time and sort of resources into it. So as we discussed before, maybe doing a future talk where I could explain what that is, and sort of launch that, because that's going to be a resource that anybody will be able to get information from.
That would be fantastic.
So yeah, that's our plan. So yeah, a future talk when that's a little bit further down sort of to being launched will be quite good. Also, what you're saying before about trainers, I think there's a whole another chat at some point about trades if you want. If you want to sort of pull my cord and let me go.
Yeah. I think we should. I think what we'll do is, if we allow people to come and feedback, I'm going to share this. Obviously, you can share this. I'll put it onto YouTube. So people who are watching it now on YouTube, you will be able to go down into the information box, and you'll have links to both of our websites, maybe contact details if that's okay with you, Sam, and so that you can get in touch and let us know if there are things you would like a biomechanics coach, exercise professional, and a podiatrist to discuss and help you, direct you, or signpost you. Maybe we can, you can get in touch and we can do that, and maybe fire off another conversation.
Yeah, so, definitely.
Really appreciate your time, Sam. Thank you so much.
Yeah, sorry for waffling on.
No, not at all. It was fantastic. I really loved it, and hopefully one day we will get to meet face to face when we come out of lockdown. But until then, stay safe, take care. Thank you so much.
Take care. Have a nice day.
And you. Bye.